afternoon, everyone. So this is a post-lunch session, so I can understand. And thank you, Gauri Madam, to moderating behalf of me. I have to leave little early, so I. Sorry. So MIGS, minimum invasive glaucoma surgery. So I think it's not the new surgery, it's a modification of the older surgery. I think long back in 1962, Barkan has done the goniotomy. I think there's some kind of what is procedure we are doing, they are almost same kind of things. So it's a new way of treating. So how we treat glaucoma, as we are listening since morning, like medical management, laser treatment, then coming to the surgery like trabeculectomy or the tube surgery. So there's a large therapeutic gap between the safer medical laser treatment versus the trabeculectomy and tube surgery. As we know, this is some sort of side effect of medication, I think already discussed. You can see even the newer drugs have the same kind of complication. Really, we have to withdraw the drugs after some time. And though really TRAB is really wonderful surgery, it's still gold standard, but not golden so far. We have seen the numerous complications following the trabeculectomy, and really it needs a lot of time to management. We have to do blood needling, as I discussed before, release suture, lot of things. So this maintenance, they really take a lot of maintenance to have the good outcome for future. And these are some nightmare you can have with the trabeculectomy. I'm not exaggerating. Really, some complications are there, but TRAB is still there. So I'm not saying TRAB is not good. And these are some few complications we can have with even the glaucoma drainage device, either way do the valve or non-valve, doesn't matter. Such complications we can have. So somehow you see here the MIGS is filling this gap, giving the good IB control with good safety. So as we know, really the ideal surgery should be the minimum harm to the eye. So these are how the MIGS is defined. It should be ab interno approach, minimally traumatic, at least modest efficacy, and have the rapid recovery, rapid visual recovery. So as we can see here how most of the MIGS works. So MIGS really works more physiologically because we are creating the channel between anterior chamber to the Salm's canal, and this is the more physiological way of working. And we see that down the line, we see the MIGS is going to be boom, and probably down the 5 or 7 year, the first choice of the surgery will be the MIGS. And where these MIGS works, what are the site? We work at the level of the trabecular meshwork, at the level of the subcontinental space, and the supracoidal space. So these are the various type of the MIGS. Or you can classify the MIGS on the basis of device-based MIGS versus the TM-based MIGS. So device-based MIGS are the gel implant, hydrous microstent, eye stent. Then coming the TM-based or trabecular-based gonio-assisted trabeculectomy, band needle-assisted goniectomy, and trabeculotomy. These are the main. So we'll discuss later. But as we might talk about the Indian scenario, really economy play a major role when we come to any kind of surgery. So what MIGS we can perform in India? So these are the few I'm going to show you. So I think these are the just summarized slide. We can do this very cheap surgeries called the bang and Taneto micro trabeculotomy, GAT, and even the eye stent, though it's a costly affair. So anyways, first of all, we have the great mental block. Like first surgeon, I have some senior surgeons are here. Really, we started SICS doing after SICS, come fake cornea will be damaged. Really, it's not good. This will happen, that will happen. I'm talking about 20 years back, I heard this. But down the line, everybody do phaco actually. So similar way, really we have to evolve, we have to change ourselves. Coming to ICC, ECC, SICS, phaco, mini phaco, femto. So I think this for glaucoma part also we have to change our mindset and we have to start new. So how to start the MIGS? First of all, you have to be good at gonioscopy. I'm talking about the intraoperative gonioscopy, know the landmarks and the intraoperative practice of the gonioscopy essential before starting the MIGS. So here are the few tips I am sharing. What we have to do as a surgeon, as a initial MIGS surgeon who are doing the phaco, they have to do practice of the direct gonioscopy while doing the phacoemulsification. So how is the angle view? Why you're not able to see angle properly? Probably this lens is fogging. You're not positioned properly, RVC coming into the cornea, or you're applying too much excessive pressure through the direct gonio lens. So so the patient and surgeon positioning is very, very important. So first we have to tilt the microscope toward ourselves 35 to 45 degree, and once we turn, then turn the patient head away from you 30 to 45 degree, similar way. So this way I'm turning the head. Then coming to some of the procedure, what we like the GAT. In this position, we have to keep our head above heart. So the reverse Trendelenburg position is ideal for the MIGS surgery. Then coming to the most commonly performed MIGS surgery, a most cost effective, I will say, in Indian scenario is a gonio-assisted transluminal trabeculectomy. In this procedure, what we do, we cannulate the Salams canal by the microcatheter. Microcatheter is costly affair, so we cannulate the canal by using the fibroproline. We will discuss later on. And really, these are I'm fortunate to visit them last month. So Dr. Fallman and Grover, they are behind this great procedure, I will say, GAT. So this is the talk about the cost. Then in which you can do the GAT actually. GAT you can do the primary open angle glaucoma, mild to moderate stage with or without cataract, though the most of the MIGS combined with the cataract surgery. And coming to the secondary open angle glaucoma, we can do in all stage. Really it works beautifully. These are the certain instruments are required. I think most of the things we have except the right gonio lens, fibroproline, and low temperature cautery, and micro forceps. These are the new things we require. Rest we have in our all over. So I think I will show the separate video to save some time. So this is the surgery in GAT. So I think this is same how I'm positioning the eye and the microscope tilt toward ourselves, and patient has go away from you 30 to 45 degree. Probably such surgery has to be done with the peripheral anesthesia, and take the high density viscoelastic. So once after I just move back here. So put the viscoelastic first onto the cornea, then dock your lens. Once you dock the lens, you can see the nice beautiful angle. After seeing the angle, this is the fibroproline. You can taper the end by using the low temperature cautery. Once you insert that suture into the anterior chamber, again dock the lens, and this is the MBR knife. We are doing the goniotomy. After making the goniotomy, again sometime the AC will shallow, then they take the forceps and thread the canal. Sometimes it takes the 20 to 22 stroke to come out the suture other side. We feel resistance at the 8 degree of the 180 degree, sometimes the 270 degree. At the end, just you have to pull out the both suture. I think this is the second case, little fast forward. I have done in the post silicon oil glaucoma. First, I am just blunting the tip. After blunting the tip, make the goniotomy. When you make the goniotomy, you see the stony white structure. This is the posterior wall of the Salams canal. And similar way, you can cannulate this suture into the Salams canal. Really, looks easy. It's not easy procedure. It has some learning curve, but not difficult. Once you do the wonderful phaco, you can do the wonderful GAT also. So these are the few surgical pulse we can keep in mind when you passing the suture inferiorly, the counterclockwise right eyes and clockwise into the left eyes. And based on the blood reflex, you can just leave some of the viscoelastic at the end of the surgery. This we published IGO video, have the detailed video about how to do the GAT, what the precaution you have to take, and what the post-operative you have to manage. Everything is there. So coming to the Kochhik blade, this is another kind of the goniotomy. This is designed by the Kochhik Malik. In this blade, what he do, just strip the part of the trabecular meshwork around the 2 to 3 o'clock our right side and 2 to 3 o'clock from the other side. So this tapered end goes into the trabecular meshwork and strip it. So I'll show in this video. So similar way, most of the time you can do before surgery or before cataract surgery, or you are a beginner, I strongly recommend to perform these MIGS procedure after finishing the phacoemulsification. I think these are the similar thing. Okay, first after having the good view of the good gonio view, really sometime if you're not having the good view, always tilt the head, adjust the microscope, sometime keep your table height and keep the high magnification. It's really is required. We have the high magnification. So MIGS procedure we should not do. If we are not able to see, don't do it. Stop yourself. And this I showed, this is the Kochi dual blade. So this is the animated part. How it is done is goes into the trabecular meshwork, strip the some part of the trabecular meshwork, right hand side, and similar way you go into the left hand side and strip it out. So this is the clinical scenario. This is the case I'm showing you. This is the way animation video. Similar way we go into the trabecular meshwork, strip out some part of the trabecular meshwork around 2 to 3 clock hour. Turn your blade when your chamber polished, make the chamber foam with the orogel or viscose, whatever you have available, but really it has to be high molecular weight, and do it. So sometimes we really get the strip nicely, sometimes really we left hand side we are not moving nicely, we are all our right hand surgeon, then really left hand keeping a balance in the left hand is a little challenging. So probably inferiorly you have some of the difficulties, but once you have practice you can do easily. So summing the folds are coming, that means I am really applying little more pressure with my left hand. That has to be avoided. At the end of that surgery, you have to thorough wash it and make the anterior chamber tight, keeping in mind the intraocular pressure should be around 30 to 40 mmHg. If blood reflex is too much, leave some part of the visco elastic, not viscoelastic, I used to have the orogel, so leave it and make the AC tight. And this is the way really the KDB again is going to, it's costly affair, $350 US, while this, what the alternative KDB we can do this, do the new process, so bent Ab-Turno needle assisted goniectomy. So in this procedure what we do, just we make the 26 gauge needle, just you bend the needle toward the bevel side, just bend it around the 45 to 60 degree, and you can perform the surgery the similar way I shows the KDB. So after doing the phacoemulsification, put the lens, and this is the I'm showing you, this is the 26 gauge needle, just I'm bending it. Bend the just tip only. Just tip is need to bend it 45 to 60 degree, so you can have the good control by you're going inside the trabecular meshwork. So though really you need little practice when you're doing before this surgery, you can take the spatula during the practice, go the spatula, touch the trabecular meshwork before doing the surgery. So this is the sharp end of the needle going into the trabecular meshwork and incise the sub part of the trabecular meshwork. So first 2 to 3 clock hour in the right hand side, then superiorly, then coming to the inferiorly. So once we come, sometimes we get the strip kind of, you can see here some tissues are there. These are trabecular meshwork. You can take it out with forceps and wash it thoroughly and make the anterior chamber as tight as around the, keeping in mind the eyepiece should be 30 to 40 mg, and sometimes you can tap, like as I say, beginner surgeons, we tap the eye how hard it is. So you can use your finger to feel it how hard it is. Though there is a question has been always raised, actually whenever you see you are disturbing the trabecular meshwork, bringing out, cutting out. So probably we are working on the new technique is called the absolute trabeculotomy. So in such specula, instead of removing, what we are keeping the tissue going to the trabecular meshwork, pulling it, bruising it. So keep the tissue, moving it, and keep the tissue here only. So that this technique, what will happen, they say stop the blocking the, what the goniotomy we created, it remain intact for the longer period of time. So we have the initial outcome published in Journal of Glaucoma, not by me, by Dr. Absolot. I'm working with him. So I have the some of the part cases I have done this Absolot. I think it's a good procedure, probably come into the near future. Then coming to the alternative, this is called the Tanito microhook trabeculotomy, is similar to the other kind of trabeculotomy. In this, advantage of these hooks are there, we can treat the canal at least more than 200 degree. So these are the various studies has published by Masuto Tanito, and he is from Japan, from I forgot the Siame University. Sorry, yeah, Siame University. April, I met him, and fortunately, I have done the more Tanito hook than more than Tanito I have done. So he and so this is the way. This is the hook. They have the right hand side, left hand side, and the straight hooks are there. Similar way, like they put the orogel into the over the cornea and dock the lens. If my time exceeds, you can stop me, please, anytime. So these hooks are really little blunt, not like a needle. Needle is quite sharp, and in this procedure, you are not removing any tissue. This is a beautiful part. So what we are going into the trabecular meshwork, just cleavaging it, not cutting it anything, just cleavaging it and keeping it apart. When you see this is a wide bony structure, this is the posterior wall of the Slem's canal. So making the direct communication between anterior chamber into the Slem's canal. So once you're sitting temporally, you can do the nasal part. As we know, the nasal part have the maximum number of the aqueous collector channel, and treating the nasal angle give the maximum IP control. Then you go to the other side, nasal side, and you treat the temporal angle. Similar way, I'm going to sitting nasal side, treating it, and at the end, like any other procedure, we can just form the AC. So we did the one study where compared the one arm is in the phacoemulsification, second arm did the phacoemulsification Tanito microtrabeculotomy. As we see, this outcome really is much better in the phaco bit Tanito microtrabeculotomy. This my article is under published in Ophthalmology Glaucoma. I will come soon. Then coming to the eye stent base, coming to eye stent, probably everybody knows the smallest stent used in the eye. You can see is the size is here so small, very tiny titanium eye stent. They have the different kind of the eye stent inject, eye stent W, eye stent infinity. So I will say just only thing is that in this procedure, we are not damaging much part of the tissue. Only a small part of the trabecular meshwork has been used to make the connection between the anterior chamber into the Slem's canal. So they suggest it's a more physiological way without disturbing the tissue. But cost is a major concern. Really, is cost. Older version of the eye stent is coming around the 95 lakhs. New version is coming around the 1,20,000. So this is the big problem with this eye stent, otherwise good devices. So this is my beginning surgery. I have not done much. I have done the few eye stent because cost is a major concern for me where I am working. So this is the trocar. We are taking the trocar. You just have to hit into trabecular meshwork between the PTM, and just you have to click it. So click it, then the eye stent stays into the trabecular meshwork connecting to the Slem's canal. Once we get, and really bleeding is a good sign of any kind of MIGS. So nothing wrong, no need to worry about the heme. They are transient, make the AC form, make the AC tight, the bleeding will be stopped. Similarly, another way, eye stent come with two, eye stent inject come with the two, one the right hand side, one at the left hand side. So once you put, then to go for the second one. Right now in that infinity is coming with the 3 eye stent, but doesn't mean you have to pay 3 lakhs. We have to pay same 1,25,000, but coming with the 3 eye stent. So you can place the 1, 2, 3 eye stent. So, but again, you talk about this cost is a big concern about the device-based MIGS. Probably soon we have the hydras also in India. They're under process. I met that person, but again, this is a challenging job. So coming to the how to make the decision in glaucoma where the MIGS stent. So MIGS always a stent between the mild to moderate glaucoma. When come to we have the good IP reduction, we need the IP in the low teens. Definitely we have to depend upon the TRAP and the GDD. So the MIGS combined with cataract surgery provide safe new option for the IP reduction. MIGS does not affect the outcome of the future incisional surgery. And trabeculectomy and tube will remain considered for when we IOP want the IOP in the low teens or very low IOP. Thank you for kind listening.
Devendra, that was good.
Thank you, sir.
Yeah. I already told you have done the maximum. Now you're telling me that you've done more Teneto than Teneto himself. That's great. Yeah. Anyway, it's always nice to hear from a person with a lot of experience, and he is one of the top people for MIGS, and we have been lucky to listen to him.
No, not like that. I'm just junior too, sir. Just learning, still learning.
Age is just a number.
Dr. Devendra, for the younger people or the people who want to start MIGS in the audience, what would you advise them to start first? I mean, what is your advice? What should they start first, and how would they go about?
Yeah. So I strongly recommend who are starting as a first learn the phaco. Yeah. Now once you've done the phaco, just you have to buy one dyed gonio lens. Right now it's coming, the eye prism SX is coming, is costing around the 4,500 rupees. Don't go for the Swan Jacob, it's costly lens, 30-40,000. Buy that lens, just start the practicing doing that direct gonioscopy intraoperatively. So what you have to do, finish your case, finish your phacoemulsification, then the way I told you, turn your head that side, turn microscope toward side, and take the spatula. Go enter into the anterior chamber. First you do the gonioscopy, try to see the angle. Sometimes you have difficulty in seeing the angle also because your left hand is pressing more, because we are not used to left hand very frequently. So keep the edge gentle, then have the coordination between right and left hand, because your both hand is engaged. One hand you have the lens, second hand you have the instrument. So take the gentle pressure over the cornea, hold it nicely, then take the spatula, just touch the trabecular meshwork. Touch and come out, touch and come out. So direct gonioscopy and just touching the trabecular meshwork, later you can perform the surgery. If you ask me what surgery you will perform first, I will always say Teneto, though that hooks are not available right now in India, but soon we will have. Though if you can't do that, you can perform the GAT, but there should be some practice or someone doing the routinely MIGS, the person should be with you, so he can guide you, do the goniectomy. This is in Bang. Bang is the first procedure I will recommend. Like
Bang
Indian
is the first
procedure.
Okay. And you use a 26 gauge needle for
Yes.
the bang.
Yeah.
Longer one or?
Longer one.
Longer one. Any questions from the audience?
Go on.
He has been saying about this gonioscopy, touch and all. It's not a joke, because you got a few microns there, you get a little tube behind, you got a cyclodialysis, iridodialysis, you're hitting the major arterial circle, it's major trouble. And you get a little forward, you're starting your DMEC. You'll do your desmetorexis.
Yeah. I would recommend really, sir, but really it's not that once you do the phaco, I can understand this, doing the procedure is a steep learning curve, but once you do the good phaco surgeon, you can try it, and only thing you have to keep your chamber always maintained. First of all, keep your chamber always maintained. Probably as a phaco surgeon, I don't know, good phaco surgeon always has the good left hand. Simple. If your left hand is good, then you can control your left hand. Keep gentle as much as you can left hand. Then make the anterior chamber always full or tight. Then you can easily perform. This is the only key factor.
Slightest pressure, you have Descemet's folds, you don't see anything.
Yep.
A little bit pressure further on the other side, you close the angle on the other side, you can't see anything.
And when you put the coupling visco, that should also be the high viscosity.
High viscosity.
So what we tend to do is we tend to skimp. We put the HPMC over the cornea. So that is not.
No.
You have to put the highly retentive visco on the cornea and the gentle pressure. And the eye prism SX, which Dr. Devendra recommended, is really good.
Yep.
And it's very economical. if you maintain it, it will come for a long period.
Yeah, I don't use. Personally, I use Swan Jacob only, but it's very costly affair. That's why
I use eye prism SX, and I feel that it is a very, very nice conule.
I learned from Swan Jacob only, so it's my routine practice. And we have to do 8, 9, 10 cases, so we keep rotating the lenses.
This can be only ETO sterilized or plasma sterilized, so you can't continue to do it.
Yeah.
The eye prism SX,
No.
gentle, one finger support. They say no, but still it will slip off. And when you're doing a maneuver, so you just
don't have to hold.
You don't have to hold with your thumb and forefinger firmly. You just have to give it support with your finger, and if needed, then grasp it and realign it. And it gives you space for your instruments to be maneuvered also, so that space is there. So that is also very convenient. Yeah, it
Yep.
goes. You can use it, but you have to be very careful. Even the cleaning of the lens, I suggest we ourselves do it at the end of the surgery and give it for packing.
Clean with distilled water.
Clean with distilled water, and don't wipe the lens with gauze and other things because it will get scratched. And once it gets scratched, it's useless.
Take my.
We have to tilt the head and the microscope. Is that eyepiece need to be tilted, or is it okay to keep it as
No,
it
no
is?
need, not play with eyepiece. You have to tilt the micro.
But eyepiece will tilt because when you tilt,
Yeah,
na,
you have
it
to
will
do
come
it.
up
Yeah,
with the
automatically
eyepiece.
tilt.
That automatic is
Automatic.
enough.
You're trying for a tangential
Yeah.
view, and if you
Tangential view.
tilted a microscope, you have not moved the eyepiece, you have to look up.
Okay. I mean, I saw a video in which
You
they were
have to, you
tilting
have to tilt it.
eyepiece
Without
also.
Only one thing I will want to add you. One thing, when you're doing routinely, you have to increase your table height a little bit because you're tilting the microscope and you have difficulty, or you will stretch yourself. You have the neck pain, back pain, all things start. So make your table height a little higher, or keep your table position like reverse Tendelberg, little up. That will solve your
Thank you.
problem.
The microscope comes like this, the eyepiece goes up,
Yes.
so that you continue to
Yeah.
see.
Okay. Thank you, ma'am.